All right. Hello, everyone. Good afternoon to some, good evening to others. My name is Chad Cook, and I'm one of the principal investigators for ForceNet, and I'll be moderating today's webinar. And again, welcome to another ForceNet webinar. We are recording this, and we will be posting it either on our ForceNet site or our YouTube channel. And if you haven't seen our previous webinars, they're actually really good. So I definitely welcome you to check those out. Briefly, here are the ground rules of the webinar. You'll notice that you're muted, but you can interact with the speaker through the chat by posting questions. We will certainly finish within the hour. Dr. George will be speaking for 40 to 45 minutes, and then we'll open it up for questions through the chat. I'll moderate those questions. Today's speaker is Dr. Stephen George, which many of you know. Dr. George is a Laszlo Ormandy Distinguished Professor of Orthopedic Surgery. He's also the therapeutic area lead for the Musculoskeletal and Surgical Sciences at the Duke Clinical Research Institute, which is the largest freestanding clinical research institution in the world. He has a secondary appointment at Duke Population, the Department of Population Health. Perhaps most recently, he was appointed as the editor-in-chief for the Journal of Physical Therapy, which is the flagship journal of the American Physical Therapy Association. And the title of his webinar is Musculoskeletal Pain Phenotype Research, Team Building, and Lessons Learned. I've worked with Steve now for 7 years. Obviously, I've known of his work for over 20. I can tell you he's one of the most humble and intelligent researchers that I've ever worked with. So, Steve, we're very happy to have you on, and the platform is yours.
Thanks. And Chad was very a key element to getting me to Duke. So I've thanked him a few times. So thank you for encouraging me to explore, and I've enjoyed working with Chad and all the others at Duke. So thanks for having me. I will showcase more of my humbleness maybe in this than my intelligence, but we'll see how this goes. But thanks for having me. Just to kind of get a few things quickly out of the way, disclosures, nothing that directly impacts this. I've been fortunate enough to have a lot of the research I'm going to talk about today funded by NIH. I am employed by Duke, which some people have an issue with, but it's not really a conflict of interest thing. It's more of an issue during basketball season too. I am editor-in-chief, which I do receive some funds for that, and the royalties for an online course for Rehab Essentials. So just wanted to disclose that. Also give a little bit of kind of where I come from. I did work as a practicing clinician, and I was always very curious about pain outcomes. And really the curiosity was driven by most of what we learned as physical therapists, especially when I trained, did not translate well at all to the clinic. That led to me having a research career, and I got into some of the psychosocial psychological aspects. Then as an educator, I've taught evidence-based practice, mostly at University of Florida, and was also have worked with some colleagues in training physical therapists in psychologically informed practice. And then as a clinical research, really just have been doing a lot of work in cohort studies and clinical trials, and really think of musculoskeletal pain as kind of they have more things, the conditions have more alike than differences. A lot of our work has been done in low back pain, but I view those as having broader lessons. And I share that I think that'll give a little bit of a perspective and context from where I'm coming from. So I'm going to talk first about the team building, and this is going to be relatively quick because there may be some questions later on. It's hard to talk about team building, I think, just out of the blue. But I did want to give an idea of why we need to build teams and what those teams might look like. And, I think we're in an era where this doesn't need to be stated, but I still do think at a time when, people are pushed to be quote unquote independent researchers, to acknowledge that, meaningful clinical research is almost always done with a team. I think you can remove that almost, but we've always been taught to never say never or always. So that almost always is there just out of, there's maybe an exception or two, but I've been very fortunate to work with strong teams. And the reason for this isn't just because the team is the way to go. I think it's because some of the questions really drive the need for people with different expertise. And this is a model that it's been updated. I still show this because this is really the model that I was looking at in building an early team of studying how chronic pain develops, and in this case, idiopathic pain. So there's no direct cause. And you can see without going into detail, there's a lot of things going on here. And to think that one person could have this expertise is, I think, a bit generous. If someone would have that, that would be amazing, but they would be far and few between. So what you need to do, I think, is think about who are the people that bring these perspectives that can help us work together to address this model. And in my case, we winnowed that model down to looking at genetic factors at the base of this pyramid and psychologic factors and how they relate to post-surgical outcomes and shoulder pain. So we took that larger model and then we moved it into something that was a digestible piece for a line of research. And this is not a unique framework. I think at the time it was novel. There have been others that have looked at this, but I think our biggest kind of step forward with this was looking at the genetic and the psychologic factors in combination and seeing how they relate to each other, and then how they may relate to intermediate pain endophenotypes and then pain phenotypes, and acknowledging that there may be some things that are related to only one of those, and there may be some things that are related to both of those. So what does a team look like? Well, the first thing you need to think about, and I think maybe that we'll see, Chad, if this qualifies for winning the bet. Um, you do have to think about how many people you want on a team, and I'm a sports person, so you think about basketball size teams up to football size teams with baseball kind of being in between. And you may kind of chuckle at this, but it is true. I think the size of the team is really important because communication is a challenge, especially when you're communicating across disciplines. So you really need to think of this. I think of it as a communication issue, and how deliberate and how intentional are we going to have to be with our communication. I think in basketball, the communication kind of becomes a little bit more spur of the moment. In football, plays have to be scripted. Everybody has to be on the same page, and I think there's some of that with the research teams. So this is what our team looked like. This was our kind of original phenotyping team, and it hasn't drastically changed. So we have renewed this RO1 and actually have a separate one from NIAM. So this phenotyping team looks like this, and again, this wasn't selected because we wanted to have equal representation. This was selected because of the research question that was driving it. And so there have been several people that asked me, well, how in the world did you get all these people to work together? And I will tell you, it has nothing to do with my interpersonal skills. It's because every one of them were interested in this question we were posing, which was how do we get better at predicting post-surgical outcomes for chronic pain? And they were interested intellectually in this theoretical framework. So that's how we got this group together. We found people that were intellectually interested in this. And then my job was to really, as the leader of this team, to really make sure we're making progress, that we're not losing sight of our original intent. And like I said, that the communication is going well enough that everyone feels like they're being heard and they're contributing what they have. So that really is the end of the team building. And like I said, we can revisit that with questions because I do plan to leave some plenty of time for questions at the end. But this slide is just to remind, that we talk a lot about diversity as we should, and inclusion, and bringing in the different team members with the different training and background is just another form, or an important form, of having diversity of thought and diversity of how we approach this. And all those different colors being around the table solving that single problem is a really important, I think, when you are dealing with complex problems like, how does chronic pain develop after surgery? So we will quickly transition into lessons learned because I think with this size, probably better to save all the questions to the end. Don't you think, Chad? Okay. So the lessons learned, and I thought I've different ways to do this, but I kind of wanted to put this in the framework of a cautionary tale. And cautionary tales are, told to warn people of danger, and they're used in the past to kind of inform people of potentially bad things happening. And fairy tales are very popular and common form of this. So children are a popular demographic for cautionary tales. And just an example, a classic example of cautionary tale is Reefer Madness, which talked about all the problems with marijuana, which, now we look, I guess we're getting close to 100 years later. That attitude has completely changed with its uses for medicinal and recreational use. But this was viewed as a cautionary tale. It also was extremely racist too, which is a different story. I think of cautionary tales, and more Knuffle Bunny comes to mind, which if you have kids my age, this was a popular book. My kids are older now, but this is the cautionary tale of losing your rabbit and wondering if it's going to come back. So those are two forms of cautionary tales, but the common element is it's a warning. And whether there's substance behind the warning or not is kind of secondary to the tale. So I wanted to put together a cautionary tale for phenotype research, and there's really three chapters in this. The first one is the Lost in Translation. The second is House of Cards, and the third is Philosophical Differences. So we will kind of go through these one chapter at a time. So Lost in Translation, a movie, but also relevant, I think, to research. And everyone is familiar, I assume. This is NCCIH's framework for translational research. Most look very similar, like to this, moving from basic questions to, how does it work or can it work, up to what does it do in the real world. And all along this translational spectrum, phenotypes want to be found. They can be identified at any stage of this translational continuum. And we're kind of taught that, maybe the more to the left you start might be a better place to look, and then in the discovery zone, and then we find that and move it along to the right to see if it works. And that's how translational research is told. That's the fable of translational research. So this is really kind of what we set apart with that team, or set on a task to do with this team. And if you hear me say BISP a lot, it's because I've been using that acronym for a long time now, and I assume everyone in the world knows it, which of course isn't true. But when I say BISP, it's the biopsychosocial influence on shoulder pain. And that is this line of research where we've been looking at identifying risk phenotypes, as I mentioned, to predict and then eventually look at precision or tailored medicine approaches that may limit the development of chronic pain following surgery. So this is just a different way of what I was showing you earlier. We are considering variation in genetic. These would be associations. So this is not, these are the genetic variations being associated with the outcome. We're not doing any fancy genetic engineering. And then in combination with psychologic factors, how do those relate into chronic post-surgical pain outcomes? In the middle, we also look at some time varying factors, whether there's changes in between that relate to the outcome. There are, but they're not going to be an important part of this story. The other thing that we've done on a translation spectrum with this framework is to look at moving from preclinical, which I'm going to talk a little bit about today, to arthroscopy. And then our current work at Duke is looking at this in arthroplasty. So we're looking at translation in a couple of different lenses here. And if and when we complete the arthroplasty study, we'll actually have a nice continuum of inducing shoulder pain in healthy people to looking at kind of end-stage shoulder pain and arthroplasty, and using a very similar theoretical framework. The translation I'm going to talk about for this talk is really in this yellow zone because that's the work that we've completed. And this kind of shows the same translational framework, but more from a strategic standpoint of, if we find something in phase 1 and then we identify a preclinical intervention, we could move that to an actual randomized clinical trial. And we have completed that in rotator cuff repair. That's the story I'm going to tell now. And we're actively doing that in total shoulder arthroplasty right now at Duke. We've recruited 13 out of 400. So in phase 1 for BISP, we did identify several candidate SNPs or genetic variations and psychologic factors. And then one particular combination was robust, and we put that forth as the risk phenotype, and that's the COMT gene variation with pain catastrophizing. And I'm summarizing a lot of work here in 1 or 2 slides. But we did this in a systematic manner. When I say it's robust, this was the only genetic and psychologic combination that was predictive in the preclinical. So the induced shoulder pain and the clinical and of arthroscopic outcomes. So this combination was the only one. We identified some combinations that were predictive in one model or the other, but this was the only one that was predictive in both. So we thought this might be something that has some utility. And this was kind of the take home from our first 5-6 years of research. And what we saw was at baseline, this risk phenotype was predicted about, you can see those hazard ratios, almost 2 times the risk of not recovering at 12 months. And we used a recovery criterion of, I think it was less than 2 at the worst and 0 for current pain. So it was a pretty strict recovery criterion. And you can see the risk of these is equal in the beginning, so that's good. We weren't picking out groups that already differed with their risk, and you can see there starts to be some separation at the 3-month, and definitely by the 9 to 12-month follow-up, you're seeing that the risk phenotype has a higher outcome for not recovering or higher. And this happened. We then adjusted for different things, and as we adjusted the model, the risk didn't drastically change. So we were kind of excited and happy with this. So the people with this risk phenotype, as it's had about double the chance of developing chronic shoulder pain. And this is interesting because this is in rotator cuff repair. And I will tell you in full disclosure, the surgeons we worked with were not wild about this model because they said no one has pain after 3 months following rotator cuff repair. And our pilot work showed that wasn't the case. And then true to form, the surgeon says, well, of course, 3 months is too early and we needed to follow them for 12 months. So I agreed wholeheartedly with that. And we got the funding to do a 12-month study. So then we moved to a phase 2 with this. This is where we're now going to test the treatments, and we're moving into what I would probably call more of a tailored approach, but we were matching treatments to the risk phenotype. And because others have looked at this comp variation, there was a pharmacologic option, propranolol, that had been investigated in temporomandibular disorder. When we were planning the study, those results were not known, but there were biological pathways that made sense. So we kind of followed that lead, and the propranolol was our pharmacologic. Because of the catastrophizing element, we know there's a lot of ways for people that catastrophize or have catastrophizing thoughts. There's a lot of ways to address that, and we developed an education program to reduce the threat of shoulder pain. And this phase 2 study was in the preclinical group. So this is not the group that was having arthroscopy. This was the group that we were going to induce exercise, induce shoulder pain with eccentric overload. And then we were going to look for pain recovery by day 5. This was the exact same endpoint that we had used in the phase 1 cohort studies. So we kept everything the same, and we chose the preclinical model, which maybe in retrospect wasn't the best choice, but we chose the preclinical model because we wanted to do a highly controlled study. We knew everyone was going to get the dose we prescribed. We knew everyone was going to get the education because we had it was all done in a laboratory setting. We had total control over it. So we thought that advantage outweighed the risk that this wasn't in a clinical population. Also, we didn't have effect size estimates, and this would allow us to do effect size estimates for an actual clinical trial. So this resulted in a 4-group design, before I show you that, where there's going to be all combinations of active versus placebo, and then the behavioral education versus a more generic anatomical education. So we had all the combinations of that, which again would be really tough to do in a clinical. So we were trying to get an idea if we needed to do a 4-arm trial or if we could drop some of these arms when we went to the clinical study. So this is the 4-group design. As I mentioned, the recovery outcome is our primary at 5 days. So people that had very low shoulder pain at 5 days. And we only recruited people that had the high risk phenotype. So this is only in people that already were predisposed to heightened pain sensitivity. And what you can see here is group C is the group that gets the match treatment for both the genetic and the psychologic component. And they had a 63% recovery rate. And unfortunately, the recovery rate for all the groups was a little bit lower than that, but it was not enough to be statistically different. There were 230. So we were supposed to enroll more, but this was one that happened during COVID. So we recruited as much as we could. We don't think power is a huge issue. The statistician did run a scenario where these differences would have, to see how large of a sample, and it would have to been 1,000. And there's a lot of question whether a 4% difference in recovery in a healthy group is really clinically relevant. Just so you know, we did power with the expectation of seeing a 20% difference. So this was a lot smaller difference than we anticipated. So, and this is not this is the humble part. This is when we're not the only ones to get to this point where we find something encouraging in a risk phenotype, and then we go to test it. And, I think what this has kind of left me to think a little bit about, which I'm sharing with you, is I think these approaches have been really, really good for understanding pain biology and processing nociception, but there really has been much smaller gains in directly improving, healthcare for people with pain. And animal models are an example of having a really low hit rate, for improving pain therapeutics. And why is that so? And there's a lot of reasons, but I, thinking big picture, when you map this translational continuum, it really moves from discovery to internal validity to external validity. And there is an assumption that the same rules apply as we go from all of those realms. But I don't know in pain if that assumption is true. And if you look at kind of the layers, pain has been described as an onion. This is one example of such onion where there's nociception, and there's an individual experience, and then there's kind of the overall impact when that individual experience interacts with society. And if you think of that translational continuum and we map on, nociception, pain experience, and impact, they line up pretty nicely with discovery, internal validity, and then the pain, and then impact. And, I think one of the things this has led me to start to think about is, phenotypes that are formed more to the left, they may not be relevant for the next layer of translation. And then the phenotypes that is formed in the pain experience, which is what we were working on in this, they may not be relevant for reducing pain impact. So instead of it being this nice translational flow from one end to the other, there's probably some breaking points along the way that need to be considered. And I think those that are interested in doing phenotype research really need to keep that in mind. And like I said, that's one of the lessons that we learned. So the second chapter is related to the House of Cards. So we have known for a while that pain is a nervous system disorder, and there's a lot of things that say that. This is just something that we were involved with. So, the thought that there are structural causes for pain is kind of a moving in the past. But what I think for phenotype research, that means need to look at the difference between phenotyping that's based on structure and phenotyping that's actually based on pain. So I'll explain that. And this is actually, I'm involved with this, but I'm not leading it. This is some of Adam Good's work, a colleague at Duke, who has access to a nice cohort that can look at some of these changes over time in both structure and also reports of pain. And what this kind of line of research did was look at structure and the changes, look at low back pain and the changes, and look at some biomarkers in families of structural changes, inflammation, and pain modulation. There's not a direct biomarker for pain, but there are some that are thought to be related to either pain perception or pain modulation. And one of the things that was interesting with this work is using unsupervised learning, you get some nice differentiation based on the biomarkers. So if you're just using the biomarkers and let them cluster through a machine learning, you get this type of clustering in a structural subgroup where some of the biomarkers are more structurally oriented. We did have to choose one as a reference group for comparisons, and then a group that had more of a pain profile. This is, and just to be clear, this isn't something that we pre-identified. This is how these biomarkers clustered mathematically, by maximizing distances, and then we had the clinical variables and did that afterwards. And one of the things that is very interesting is if you look at the structural change subgroup, when you look at the presence of structural changes, that subgroup has those. When you look at the pain and the inflammation subgroup, that has the biomarkers that are more affiliated with increased inflammatory responses and decreased pain modulation. The association with structure is not there, but it is with the reporting of back pain. So that's the red. The blue are the associations with structure. And you might say, well, that kind of makes sense. And I think it does, but not many people look at them this to have both of these options. Sometimes it's one or the other. And a lot of work has been done in identifying the structures that are supposedly related to pain versus those that may be related to pain or versus those that report pain themselves. The other thing that is interesting about this work is we've been able to follow this longitudinally. So those were identified at one point in time, and then we were able to follow whether the structure got worse or whether the low back pain worsened. And this is a very interesting exercise, similar to what happened to us when we moved things along. The biomarkers that look good in cross section look less good in longitudinal analyses, and that's really what we're probably most interested in is how do these things, not necessarily only how do they relate at one point in time, but can they help us predict. The red line is on all the biomarkers that have essentially even association. In this case, it's structure. So there's a few related to structure that are related to the changes in structure. And then in low back pain, look at the incredible variability, first of all, and then second of all, there are most, I think all actually cross 1.0 for this one. So the House of Cards chapter is a shorter one, but it is just reinforcing that structural and pain phenotypes will differ. And if you're only looking for structural changes, you're going to get structural subgroups, which is great, but they may not relate to pain outcomes. And I may be preaching to a choir here, but I can tell you there's lots of interest in structure and phenotyping structure. It is definitely more of an identifiable thing to phenotype, but the assumption that increased structural changes will relate in pain phenotypes is easily dispelled, and this work by Dr. Good and his colleagues shows that quite well. And then the other kind of fly in the ointment is when you start looking at things longitudinally, they may not look as promising as they do in the cross section. This is true for all research, but again, when we do the phenotyping research, the standard I think needs to be the longitudinal work and not the cross sectional work if we're thinking about using this, to help with patient care. All right, the last chapter, chapter 3. This is the philosophical differences. Give people a second to look at this cartoon, and then I'll take a drink of water. And this is something that I think about quite a bit in studying pain is this idea of, it's one thing to postulate a goal, and it's quite another to say that science is capable of achieving that goal. And when you look at the definition of pain, it's really challenging to study this with this kind of absolute lens that we're going to get a definite answer or that science is going to solve this. And I revisited, I did a postdoc at the University of Florida in a lab when these papers were coming out. And interestingly, it was one person from Florida and one person for Duke, maybe a little bit of premonition of my future there. But this idea that there are some serious philosophical issues in pain research. And I like this idea of the striking contrast between pain and vision, hearing, and touch. And if you think of it, with touch and hearing and sight, you can externally validate those experiences when they're tested. And so this leads to the focus is on what the content is and not the perceptual experience. When your vision is tested, they're not asking you, what do you think about you're seeing this? They're asking if you can read and what improves the ability to read that at a certain line. And we don't have that same option for pain research. So what happens is what is experienced becomes the focus of the perception. We're not testing this perception directly. And that means, that the experience becomes painful and the object that is causing the pain is not what we're focused in on. And I think this quote kind of summarizes this a little bit. So to feel pain is private, but to feel the pin is not to feel the pain. This is a common way, people test pain perception. And I like this last part. It is not the ability to feel pins, which we are, measuring, but the ability to feel pains. But the only way we can do that, is through the use of external stimuli, at least in this type of paradigm where we're controlling the stimulus and trying to get some responses. So this is back a little bit to the House of Cards, but I do think, this is back to structure versus pain, but I do think there are some differences. And, this is this tension that that there's a subjective understanding of pain versus how we can objectively characterize it. And this is a fundamental question. and it's highly relevant for phenotyping, and I'll get to that, I promise. The I stayed at a Holiday Inn Express philosophy lesson is almost over. So this is one. There are a lot of paradigms for testing, whether biomarkers that are favorable in preclinical lands are should be studied in the human. And this is one very elegant example from Karen Davis. But I like to boil it. This is back to my EVP roots. I like to boil it down to a 2x2 table because I spent many years trying to get poor physical therapy students to understand this. But I do think this is highly relevant for phenotyping. No one is going to complain. The smiley faces are happy, right? No one is going to be upset if the biomarker results suggest that the person should have pain and they report pain, and same with the negative. So that those are easy. Where it gets interesting is, what happens when the biomarker says, well, this person should be experiencing, or should have chronic pain or whatever it is. That's a little bit concerning. And then the biggest, from the philosophical perspective, is what do we do with the people who subjectively report pain, but the biomarker or whatever it is, it doesn't have to be a biomarker, it can be any measure, suggests they shouldn't. And this is where you're going to see all kinds of reactions, and that's what these faces are meant to imply. And some of them are skepticism, some of them are, oh, really, you're in pain. And I know no one on this call would have that reaction, but all it does is take a little look in the literature to see about the stigma of experiencing pain without having a diagnostic, a certainty. To know people get these responses, again, somehow magically not from anyone on this call, but from other people. So what we're left with is this 2x2 that shows when things align, we're fine with it. But there are some serious issues when the subjective report does not line up with the objective result. And the biggest concern is that corner that has all the different faces, because this is now suggesting that the subjective report of pain shouldn't be there. So this results in what I'm calling, a philosophical cul-de-sac, where we have a promising discovery, develop and refine it to be a marker or a pain phenotype. But then we're left with this clinical validation is always linked to the self-report. And one of the early kind of tips of the spear for this issue was fMRI. And this was something that I was an innocent bystander of in the lab that I did my postdoc, but was very interested in this issue applies to many, many different measurement, but I think it's most well developed in fMRI, where there is a new way to look at neural mechanisms, but the way those neural mechanisms are confirmed is through the self-report. And this lack of kind of foundation that the brain imaging would replace that self-report. And most people who do fMRI research, I think, are well aware of this, by the way. But I think the issue is when people start to get into what will the phenotype be, what would a brain imaging phenotype be, or signature, if you will. And this was, I think, like I said, first brought about by fMRI, these arguments. But I think you can put any phenotyping approach that relies on self-report of pain to validate, with the goal of that being the only way to identify, will always fall short on the philosophical foundation, as long as we accept that pain is a subjective experience. And this is challenging because there's a lot of push for objective measures of pain, which I think, to be frank, shows a lack of understanding of some of these philosophical issues. So that is the cautionary tale, going from lost in translation, and how effective has that been, and what is the implication of that for phenotyping. I think it means you need to think local. If you want to change pain impact, then your phenotype better be very close to the impact of it. Don't start at nociception if you want to change the impact. The house of cards is fairly straightforward, but consistently see people who are hung up on structure and trying to equate that with pain, that it might be more effective. It will be more frustrating to phenotype pain directly. And then the philosophical part is that this objectification of pain and phenotyping, um, phenotyping can be done in a way where that tension is acknowledged, or it can be a way where it plays right into that tension, and it will cause problems down the road. So that is that. This is kind of just a fun. It would be better, around Halloween time perhaps, or if we dim the lights. But I do think, this is, I'm not pointing fingers at other people as much as this is what we have learned with that team about some of the approaches to phenotyping and what we've done. And, I think, that hear our stories and take heed, and, but remember there's other there's other people watching too. So I think I stayed on time. Um, Most of the work I highlighted was NIAM's work, funded work, but I have had some NCCIH funding too that has maybe indirectly informed this. I think Chad and I are working on a project that we'll be unpacking from NCCIH over the next couple of years that I think will really help us understand some of that right end translation. So thank both of my funders, and thank you for listening, and hopefully some people enjoyed the cautionary tale framework as much as I did in putting it together. So thank you.
Right, well done, Dr. George. And we'll now open up our question answer period. As a reminder, we take the questions through the chat. Steve, I'm going to start with one first because I think it's going to be relevant for the next question. In chapter 2 in the House of Cards, you talk about structure. Can you just give some examples of what you mean tissue-wise by structure that are commonly looked at?
Yeah, I mean, obviously, disc, it used to be disc herniation, annular, there's a lot of different things. I think some of Adam's work focuses in on, cartilaginous changes in and around the disc. It could also be, stenosis. It could be narrowing. People have started looking at myofascial things now. So I kind of group a lot of those together that, in my experiences and the data that we've had access to, the variation in the structure does not correlate as well as we would like it to with the variation in the pain reports. And I think, if your phenotyping target is that structure, it's fine. But I think what you see are a lot of limitations then when you want to apply it to the next step. And I'm not even talking about the pain-related disability. I think that's even, what we are focused on is really intensity reporting, which I think is even different than the pain disability. Does that help?
Very much. And so we have a question from Peter. It says, philosophical issue number 1, does potential tissue damage constitute a structural issue, or is it something else?
Does potential tissue damage? I would say that is probably something else.
Okay.
And I'm happy to clarify that a little bit more because I'm not sure I completely
Please do.
understand the yeah. Well, I mean, if the person who asked it can clarify, or I don't know if they're allowed to unmute. I took it more as a multiple choice question, and I picked my answer. But if there's a essay component, I'm happy to address that.
So Peter, please chime in on the chat if there's additional follow-up. And while we're at that, Mike has a question. So much progress is being made in the qualitative world with pain care. Do you see mixed methods playing more of a role in these research teams for phenotyping?
I think definitely, and I think it would be really interesting to see how that would be applied. I think one area that hasn't been fully explored for phenotyping, and we talked a little bit about it, is patient preference and patient expectations. And I think to really get at that, that mixed methods qualitative piece would be incredibly informative because I think we only get a little bit of a glimpse of that when we use standardized questionnaires. I think if it's a model that we were using before with the genetic, I think where the qualitative part would be very helpful is, well, how do we describe that to people? How does that help, with the care? We had a little bit of this with one of the clinical trials I worked on, and trying to avoid the stigma of receiving psychologically informed care. And the patient perspective on that was very, very helpful. So I could see some of that qualitative work, especially informing delivery models too, and getting a sense from the patient. Did this just increase their stigma? It's just a different label, or did it actually aid their care and aid communication? But I think where it would be really cool is the preferences and expectations, informing that directly.
A great answer. And we have a question from Greg who is part of ForceNet. Great talk. With your conclusions, are there emerging methodologies that can move this area forward?
Well, I think there are. I think part of it is just getting some people to take an honest. I think of it less as a methodologic issue and more of an issue of how far away from on that translational spectrum do I want to build my phenotype to see if it impacts patient care. And what I'm kind of in the stage in the last 10, 15 years where I'm going to be on the research treadmill, running as hard as I can. I just keep the work I've been in pushes more and more to the right, that this idea of finding a phenotype that has a nociceptive element and then moving that all along to actually changing a care model, is way beyond what we can do right now. So I think it's less. I think our methods are pretty good, actually. I think it's more of a, where do I start? What are the measures I want to use to characterize this? Does it have to be mechanistic? Can it be a phenotype based on preferences and expectations, and moving that forward? So hopefully that makes sense, Greg. I view it more as kind of, where do I want to start? Where do I want to end up? And if I overcorrect by starting too far in the sciencey direction, I'm probably setting myself up for failure.
Question from Jen, also from ForceNet. Do you think chronic pain is more of a fixed allele situation versus genetic drift in the samples we're taking in the population?
I'm not an expert geneticist. I think, my understanding is the genetic variation, whether it's how we looked at it, kind of just with the genetic associations or the epigenetic, it's a small contributor to the vulnerability to chronic pain. And there are some instances where that vulnerability can be such that it's highly likely, but there are a lot of other factors, that contribute. So I see it as one part of, a multifactorial component, and I'm sure that doesn't directly answer that. But if Peggy, our geneticist, was here, she would. This would be a time I'd turn it over to her, and she might be able to give you a more informed answer.
There's a question from Ryan. He says IASP's definition includes potential tissue damage. Do you have a clarification for that? It just seems a little nebulous. Is it purposely nebulous?
I would say yes, it's purposely nebulous. I think there are some paradigms where you can, this really ties into the subjective part, where someone can report experiencing pain and there's no evidence that tissue has been damaged. And the move towards that, and Vitali's on here, there's probably others can correct me that are active in the pain research world, that is intentionally meant to take the onus off of, there's a physical cause of the pain. Torture is often used as an example, where just the threat of being tortured and some of the things that can happen, people report pain. That's an extreme example. But I even think clinically, we don't have a definite imaging finding that suggests someone should have back pain. We have high sensitivity, but we have zero specificity for imaging findings. So I think it's it purposely nebulous, and it also keeps the person's subjective experience as the kind of the gold standard for what is painful and what isn't.
Steve, I
I don't
have
know,
one.
Vitaly, do you want to, or Vitaly can add something in. He's better at this than I am, so he can add some stuff
I
in the
have to
chat.
look.
Or he can add it in the chat. I don't know what is easiest.
Yeah,
I don't mean to put him on spot. If he thinks that's a good answer, he can. Um,
maybe.
I just think that part of the definition has been there a while is another way to answer that. When they updated the definition, that was not a part that was revisited as best I am aware.
So Vitaly, if you don't mind using the chat, because I can't find you on the board here, but I've got a question through the text, Steve, and it asks, you've done translational research across the spectrum. Is there always an underlying clinical research question in every domain, whether it's mechanistic, whether it's preclinical, whether it's clinical research? Is there always some anchor to the clinic for you?
I would say yes. I mean, I started as a clinician, and um, most of the questions that were, interesting to me still remain interesting to me. So I think I drive very hard to the right of that spectrum and finding out, is it is it is it better? Is it better treatment? What are the clinical outcomes? And if I can find the mechanisms along the way, great. But I'm not going to let that hang me up, on then finding the clinical outcome question.
Gotcha. We've got Peter again with a question. Nociplastic pain is a phenotype that appears to encompass individual variations in nociception. Ultimately, doesn't nociplasticity or variations in nociception, in fact, constitute a structure?
I think it could. I think as it's operationalized now, um, it would be a very different structure than what has been classically focused in on as structure. And I think, we have a long way to go with these characterizations, the newer characterizations, and there's tremendous overlap in nocioplastic and other, they're not mutually exclusive. But I do think there is a risk that they, could be the new generation structure. I just think they're different. And as someone who's done more quantitative sensory testing than I ever thought I would do, the variation in those responses are such that you can't differentiate just on that, what is pathological and what is not. And that's a very different mindset than how the structural mindset started, which is, there's pathology in the variation in structure. And the only thing that is normal is like a 20-year-old spine. But I do agree that could be the next wave of structure, and it'll be interesting to see how that evolves.
All right, I'm asking Medha to unmute primarily because she uses a couple of abbreviations that I'll probably butcher. So do you mind asking your question?
Thanks, Chad. Thank you, Dr. George, for a really interesting talk. So I was quite interested by your finding of the link to the COMT SNP and pain catastrophization. So given that, would it be possible to identify people who have, and I think it was the slow variant of the COMT gene that was associated with, who have the slow variant, to give them dietary supplements or pharmacological agents that maybe compensate for that reduction in activity and prevent the transition to chronic pain in those people?
Yeah, I think, as I mentioned, we were following along the temporomandibular, which was using propranolol, which I don't know all the mechanisms, but I think was more related to some of the neurotransmission. And so there would be other pathways to explore with the COMT that, I think maybe would be better. The TMD story is as equally frustrating as ours. There's some conflicting evidence in the two trials of whether, the propranolol works. So I think if we think this is a risk element, looking at other therapeutic agents that are, maybe like you said, dietary make a lot of sense. I will say, one of the weaknesses of our preclinical study is we didn't do any functional things. We just had their association. So we have some circulating, we had the blood, so we've looked at some biomarkers and published on that, but we didn't have anything that really would have let us look specifically at some of the comp pathways that maybe would have informed a better, therapeutic target. So that's some other place to go. But there is animal work in this, and like I said, maybe look at some of the TMD studies that have used that as a therapeutic agent. But I think it's encouraging, an encouraging direction.
Thank you for that. We're going to get you out of here on this question. This may or may not be from a biostatistician. How early in the planning process do you engage a biostatistician when you're developing your team?
As early as possible, I guess. I've been, I think I had a statistician on that list. If not, so that first study at UF with the rotator cuff, I think we got it funded in 2008. We had a biostats person on the team. Sam Wu was our first statistician in 2006. So he was involved with all the pilot data, helping us plan sample sizes and things like that. So I am very codependent. I would like to think it's codependent, although I think I get more out of it than they do sometimes. And it's very helpful for lots and lots of reasons. But most importantly, it just helps you make good decisions about, are you adequately powered? If you're not, what are things that you can do to make that up? And we always go in with an a priori statistical analysis plan that we stick with, because there's plenty of room for secondary, but the statistician helps us lead that part that we're going to analyze the data well before we, have it collected. So it helps keep us, I think, on the right side of that ledger for the involvement of the statistician. So.
Well, Steve, on behalf of ForceNet and certainly the U24s, thanks a ton for this. We really enjoyed it. And audience, it's like a who's who of amazing researchers in this group. So thanks everybody for attending. Just as a reminder, we do have another coming up with Dr. Helene Langevin, NCCIH director. That'll be in a couple of months, and we'll keep you posted on that. Thank you all, and we certainly appreciate it.